Thank you. So I wanted to really kind of talk about a subject that I think is of interest, race and cardiovascular disease, especially in light of recent events that have taken place both in the United States and around the world. And I think this is a great opportunity for us to maybe even discuss how this may apply to us, uh, especially as we see a change in the population, not only in Canada as a whole, but even especially in Atlantic Canada and in New Brunswick. So as I said, the Hippocratic Oath was instituted over 2,500 years ago. And the basic tenet behind this oath is that we as physicians and as healthcare professionals in general do no harm. But over the past century, I think race and medicine has had really a very sordid relationship. If we look at medicine in the Third Reich during Nazi Germany, many experiments were conducted in both Jewish people and non-Jewish people by members of the Third Reich. And this led to obviously the basic principle of racial cleansing, but of course there were other inspirations behind this, unfortunately. During World War II, medical experimentation in Japan was not uncommon. In fact, they used prisoners and oftentimes would mutilate them, disfigure them in the spirit of medical science in an effort to experiment and to further their scientific knowledge. And then, of course, I think most of us who have spent any time looking at ethics in the context of medicine are familiar with the Tuskegee syphilis experiment. And for those of you who are not, this was actually a study that was introduced by the US Public Health Service in 1932, where about 600 African Americans in Mason County, Alabama, were enrolled in a study. And really what the purpose of the study was to look at the natural history of latent syphilis. But this is not what these individuals were told. They were told that they would be followed and offered the best medical therapy. But unfortunately, when penicillin was introduced in 1947, they were never offered this. This was really supposed to be just a 6-month study, and it carried on for a total of 40 years. And it was only in 1972 that the study was actually terminated. And it was only terminated because the context of the study and contents of the results were actually leaked. So it's sad because this is within our lifespans for some of us, obviously not all of us. So many ethical issues have come from the practice of medicine, especially as it relates to race. Harm to patients obviously is the main thing that kind of comes to mind when you see these three examples. What's also sad is that a lot of these examples were led by physicians in the medical community. This is not something that physicians were roped into. Oftentimes it was them that were driving these particular studies, whether to be further knowledge or in some cases to be in lockstep with the political agenda that was in place. So hence the fact that these were highly politicized events is somewhat frightening and highly disappointing. So, of course, the Declaration of Geneva, which is probably the most obvious successor to the Hippocratic Oath, was instituted in 1948, really as a way to kind of realign everyone's thinking. And the core tenets that I wanted to kind of bring up was that, first of all, you would respect the autonomy and dignity of your patient, that you would maintain the utmost respect for human life, and that you wouldn't permit considerations of age, disease, or disability, creed, ethnic origin, gender, nationality, political affiliation, race, sexual orientation, social standing, or any other factor to intervene between duty and patient. And it's interesting because a lot of the terminology that's used in that was stated in 1948, but really feels very current and very modern. So now let's roll forward. We just celebrated Martin Luther King Day on January the 18th. Martin Luther King obviously is one of the most renowned individuals as it relates to civil rights movements in the United States and obviously worldwide. Martin Luther King Day is celebrated in and around the time of his birthday, which is actually January the 15th, but obviously they will move it back and forth in order to kind of position it on a Monday, typically after the long weekend. And of course, the civil rights movement was initiated in the 50s and the 60s to offset and try to kind of fight against years of oppression and a lot of the things that Blacks in the United States were suffering from whether it be segregation in schools and on buses, lack of the ability to vote, job inequalities, et cetera, et cetera. Now let's fast forward almost 30 years to the riots of Los Angeles. The riots of Los Angeles were in response to the Rodney King assault. And I mean, if you hear the story of the Rodney King assault, it's very much like a lot of the stories that we've heard in the past year. Rodney King and two of his friends were in a car, and they were being pulled over on the highway for a routine traffic stop. Unfortunately, Rodney King's personal history included arrests, and he was currently on parole. And unfortunately, he felt that because he would be pulled over, he would lose his parole and he would be put back in prison. So this ended up in a high-speed car chase. How this really ends, though, is the fact that there was a disproportionate level of assault or violence in terms of the police directed towards the individuals involved. And this resulted in the incredible riots of Los Angeles that many of us will actually remember. Obviously, it didn't play out in the setting of a 24-hour news cycle the way things do now, but really many of the riots that took place during that time were well documented, number one. Number two, they fell on the backdrop of a lot of social tension in Los Angeles, especially as it related to the infighting between Black African Americans and the Koreans, hence why a lot of the rioting took place in Koreatown in Los Angeles. And here we are now, 28 plus years later, and we're still dealing with a lot of what we saw back then, and not much has changed. Of course, many of us will remember the George Floyd incident, where he unfortunately passed away on May the 25th of this past year during the COVID pandemic. This is a screenshot from a video that was taken alongside the actual event. And really what this sparked was a huge Black Lives Matter movement. And this Black Lives Matter movement kind of spread not only within the United States, but across the world. And we saw it here, even in St. John. But unfortunately, the Black Lives Matter came up against a lot of other social movements that were taking place simultaneously. This was a reaction to the Black Lives Matter movement and an eventual rally that was to take place in Washington, where basically, quote unquote, peaceful protesters, and I use quote unquote only because I'm making the assumption based on what people are reporting that they were peaceful, were told that they were not to be in that area. They were tear gassed and pushed away so that a said individual could have a photo opportunity. And then this, of course, is the famous picture that came out recently. And this was in preparation for the protests that were to be held at the foot of the Lincoln Monument. And this is the National Guard that was deployed in Washington and across the United States. A total of 20,000 members of the National Guard were mobilized for this particular for these particular protests, which is just absolutely incredible, especially when you look at what happened here on what is now being famously referred to or infamously referred to as 1/6, which were the riots at the Capitol, where there was felt to be a very little of any reaction to the race-driven protests that were happening earlier just 1 year ago. So what about race and cardiovascular disease? Where are we with respect to that? So some of the data I'm going to show early on is related obviously to the US, because that's where the bulk of the data exists. Now, if we look at data from the American College of Cardiology as well as the CDC, you see that Blacks have the highest rates of cardiovascular disease in the United States. It's an astounding number. And they're 2 to 3 times more likely than whites to die of heart disease. And they're also 33% more likely than whites to die of cardiovascular disease in a hospital setting, assuming that everything else is equal. So this is after they finally get into a hospital setting. And we are seeing here on this graph that very representation of the racial and ethnic disparities that exist in age-adjusted death rates for heart disease by race and obviously Hispanic origin. There's a huge disparity in risk factors in the United States as it relates once again to color and to Hispanic origin. Black Americans are very likely to have hypertension as compared to anybody else. And in fact, their rates of hypertension are the highest in the world. Hispanics and Blacks are also likely to have the highest rates of obesity. There's also disparities in diabetes and total cholesterol as well. What about COVID-19? Because there was a lot that came out about race and COVID-19. And this was a study that came out in the New England Journal this past year, where they looked at an integrated health delivery system in Louisiana. And this particular system, the population is 31% Black and 65% white non-Hispanics. And they looked at the rate of COVID positive patients between March 1st and April the 11th of 2020. There was a total of 3,400 cases, of which 70% were Black. So you just look at the disparity now between the actual number of Black patients or Black people in this county and the number of cases that were COVID positive and who were Black. The Black patients who were affected by COVID-19 had a higher prevalence of obesity, diabetes, hypertension, and chronic kidney disease. 39.7% of these COVID cases were hospitalized, of which 77% were Black. Of the 326 who died, 71% were Black. But interestingly, following a risk adjustment where you say, all right, I'm going to adjust for all the differences in their comorbid diseases, there was actually no difference in mortality that was found between Blacks and whites. And numerous studies have come out since then that have shown a very similar finding, which is, yes, the rates of COVID were higher amongst Black people. The number of Black people who died with COVID were much higher as well. But once you take into account all the differences, the socioeconomic differences, the differences in comorbid disease, including hypertension and diabetes, et cetera, actually the mortality rate's the same. Unfortunately, though, what's being omitted in all of this is the fact that a lot of these risk factors are the ones that drive the mortality in the first place. They drive the likelihood of developing COVID-19 and a lethal version of COVID-19. So what about Canada? Does this even happen in Canada? Do we even have a race issue in Canada? Well, interestingly, if you look back, Jack, to back in 2010, he looked at cardiovascular risk profiles among ethnic groups using population health surveys between 1996 and 2007. And he found that between white, South Asians, Chinese, and Blacks in Ontario, there was a striking difference in risk factor profiles. As far as prevalence of heart disease was concerned, this ranged from a low of 3.2% of the Chinese population to as high as 5.2% in the South Asian population. And then although the Black population had the least favorable cardiovascular risk factor profile overall, interestingly, it had a lower prevalence of heart disease. So this is a bit different than obviously what we're seeing in the United States. A follow-up to that study was published in the British Medical Journal in 2015, where once again, they show that a temporal trend in diabetes, obesity, current smoking, and hypertension between males and females existed. And that once again, you could really kind of use these to sort of predict where it was that you would be now and in the future. For instance, diabetes increased 2.3-fold in South Asian males and 1.9-fold amongst Black females. And this is all happening in Ontario. First Nations are not exempt, obviously. First Nations are one of the high priority groups that are being vaccinated for COVID-19 in New Brunswick, and that is for a reason. This particular study by Sonia Anand and Hamilton and her colleagues, Monica, this isn't you, by the way, showed that Indigenous people were known to have higher rates of chronic disease and reduced life expectancy. But what about cardiovascular risk factor burden? We assume that that is higher. But what they found was that there was a fair amount of variability between 8 different First Nations communities, and that the lower risk score were in communities that had higher socioeconomic status, greater trust, social support, and educational opportunities. But those that had the higher inter-heart risk score was where it was difficult to access care or afford prescriptions. And of course, this goes on and on. There's other studies that are coming out. This is a review that was recently published in the Canadian Journal of Cardiology looking at South Asians that are residing in Canada and a reflection of the heart disease that's found in these people. And I chose not to read it because this directly involves me personally. So what about as Atlantic Canadians? Can this be happening here? Let's be honest, we don't often think of race and inequality from that standpoint happening in Atlantic Canada. A large amount of that has to do with the fact that we have a fairly uniform population, or so we think. These are studies that I was directly involved with, where we didn't look necessarily at race, but we looked at things like place of residence and distance from a tertiary care center. And what I found was that where you lived very much impacted on access to cardiac care in Nova Scotia. It impacted on your outcomes following cardiac surgery, and it also impacted on the differences that we saw in gender in terms of post-cardiac surgical outcomes, both short-term and long-term. Immigration is becoming an increasingly bigger phenomenon in New Brunswick. It is being used for a variety of reasons, but one of them is to really bolster the population in New Brunswick and to increase the multiculturalism and the diversity in this province. If you look at the immigrants to New Brunswick over the past 20 years, you can see these are the number of immigrants that came to New Brunswick each and every year over this time frame. And the number is increasing. While 4,000 to 5,000 doesn't seem like a lot, it is when you add it up over time. And if you look at the overall number of immigrants as per Stats Canada, you can see now that we're almost up to about 35,000 immigrants. And this is out of a total of 780,000 people in New Brunswick. So this is interesting. And then obviously the percentage of the overall population that's immigrants is increasing as well. If you look at the distribution by zone, you can see that the highest rates of immigration are in the areas of zone 1, 2, and 3, between 5 and 8%. However, it's not to say that there aren't immigrants in other parts of the province as well, between 2 and 4%. Unfortunately, though, 50% of immigrants apparently in this province leave after 5 years. I have stayed, but other people will leave. Having said that, interestingly, though, if the overall rate of immigration is higher, despite the fact that some of them are bound to leave, a lot of them are likely to stay. And if we look at visible minorities, this is in New Brunswick. These are the number of people who identify themselves as a visible minority. We have a fairly large amount of people who are Black, Chinese, and South Asian. And increasingly, we are starting to see more and more Arabs. This has to do with, obviously, with the influx of Syrian refugees, but also other populations that are starting to move to New Brunswick and Atlantic Canada as a whole. What about the Indigenous and Aboriginal population? This is not an insignificant population. If we're going to talk about immigrants being about 30 to 35,000, well, there's almost as many Indigenous Aboriginal people in this province as well, of varying degrees or varying backgrounds. So once again, this is accounting for almost 1/7 to 1/8 of our overall population. But what do we know about these populations? I can tell you personally, I don't feel like I see this population being well represented in my patient population. I feel like I see a predominantly white population, and the biggest differences are between, I guess not differences, but the language differences are the biggest differences that I see. Increasingly, I'm starting to see a little bit more, but I don't feel like it represents 10% of my patient population. So we don't know much. We don't know what their cardiovascular disease burden is, what their risk factor burden is, what their access to care in New Brunswick is, what barriers exist in terms of this access. Once in the system, do they actually experience similar outcomes? Interestingly, this was a study done by Dr. Phil Tremblay, who's a resident in cardiac surgery in Halifax, and he measured access to cardiac care for visible minorities and Indigenous populations across all of Canada using Statistics Canada data. Now, the data is a bit outdated, but what he found interestingly was that the odds of you receiving a CABG and or a PCI were slightly diminished across Canada if you were a visible minority or an Indigenous patient or an individual. But if you look at Nova Scotia, that likelihood reduced considerably down to between 51 and 58% respectively. That's a considerable drop. And you have to wonder if that's not happening here in New Brunswick. So what do we do? I think it's time to carve a new path going forward. I think no longer can we assume that we are not seeing people who are Black, Indigenous, or of color, because there are no people who are Black, Indigenous, or of color in New Brunswick. We need to start collecting data or seek out data that may already exist on this particular subject matter. And I think we need to engage the disparities that likely exist. If you look at racism, this was an interesting paper that was put out in 2000 by Dr. Kamara Jones. And what she did was basically identify 3 levels of racism. Racism can be institutional, where and this is what was referred to as systemic racism, where there's differential access to goods, services, and opportunities by race. It's kind of a normative form of racism. It's just assumed that it's there. There's personally mediated racism, which is, I think, what most of us think racism is, which is prejudice and discrimination. But that's really only one of the different kinds of racism. And finally, there's internalized racism. And we can't ignore this, where there's almost an acceptance by the members of the stigmatized races of those negative messages that are out there about their abilities and their own intrinsic worth. So we have to, when we are going to combat racism or combat systemic issues, we have to think of it as in multiple levels. This isn't just a government problem or a white versus colored problem. This is a problem that occurs at all levels. And this was a commentary that was recently published in the CMHA, where really it said, we can't think of racism, or we can't think of systemic biases as being something that happens south of the border. This happens in Canada too, and we have to start addressing it. And we can't limit ourselves to just Black people. We got to think of Indigenous people, people of color, women, and obviously people of different sexuality. These are all things that we have to think of as cardiovascular disease practitioners as we try to expand our horizons and our thinking. So I'm going to finish off with this quote by somebody who just passed away. He was truly the home run king, and he received no shortage of death threats as he was approaching Babe Ruth's record of 715 home runs. And unfortunately, he was passed eventually by a Barry Bonds, but it's a tainted pass. But what he said was very interesting in 2014. He goes, "We've moved in the right direction and there's been improvements, but we still have a long ways to go in this country. The bigger difference is that back then they had hoods. Now they have neckties and starched shirts." Thank you very much. This is actually from the Black Lives Matter movement in a rally here in St. John on June the 14th. Thank you very much. All right.
Well, thank you, Ansar. Wow, very good. I'm wondering if you would comment a little more on, I completely agree with you that the issue around data and starting to collect data, and your thoughts on how to do that and how to sort of navigate the sensitivities there might be around collecting some of that data. And obviously something that we need to address and understand better and all of that.
So I think that's a great point, and I think that's got to be our first step. If you look at our approach database, for instance, or the STS database that we've had for years, we've never explicitly gone out and collected data on race. We even try not to explicitly collect data on language and religion and education and all of that, because it's assumed that that's not important to the care of the patient. But I would argue that these are actually important factors, and if we don't begin to study them, then we won't ever understand what the impact of these factors are on patient outcomes. I think, we have to kind of get around the sensitivity issue. I think more and more forms that you're starting to fill out, I think you're starting to see that they're asking for these informations. I think the COVID form, for instance, when for those of us who got the first shot of the vaccine, you were actually filling out all of these data points. Other forms that I filled out for grant applications, I've even now started to ask for pronouns. I think these are important things that just need to be dealt with. And if we don't collect the data, like I said, we will never know. So, I mean, what you see in the United States is that they've embraced this for years. They don't even think about it. They ask about whether you're Black, you're white, you're Hispanic, you're not Hispanic. And I think that's just the basic kind of starting point. Yes, you don't want to necessarily pigeonhole yourself into a group, or pigeonhole yourself into a group. I think that kind of speaks a little bit to that intrinsic racism. But having said that, if you don't identify a potentially at-risk population, it's almost like saying, well, I don't really want to know if you're diabetic or not. I don't really want to know if you're hypertensive or not. I just know that you came in with 3-vessel coronary disease. I'm going to treat that.
Yeah, very interesting.
No, I think this is, look, you and I are starting to see, like, I'm just speaking from the St. John perspective, but you see it in Moncton and Fredericton, especially also when you go to the malls, when you go out, you are starting to see more and more people of color. I'm actually very surprised by the number of people that are out there, not to kind of target them socioeconomically, but if you go to a Walmart, for instance, or you go to like a superstore in a different part of the town, you actually see this population, and you can see how the stores are catering to them by bringing in things like halal meat and bringing in different kinds of ethnic background foods, etc. I think, I think these are all people, provided that they stay, and you know, some percentage of them are going to stay. And I think with COVID being better in Atlantic Canada than in other parts of the country, you're going to start seeing more of them come here and stay. I think this is going to be something that we're going to have to think about. I really don't see very many. You know, I can't tell you how many people of South Asian descent I see in my practice, but it's I can count them on one hand, and that's disproportionate to the number of people that are actually here.
Yeah, I agree. The
Ansar?
population. Yeah.
Yeah.
Sorry, go ahead.
What about the problem of, and thank you very much for this. I think this is an area that we need to talk a lot more about. And as we talk more about it, I think we'll become better at addressing the issues and hopefully normalizing people into society. What about and I've seen this happen at our hospital more than once. What about the issues, and I'll use the word reverse discrimination, where you are discriminated against personally by patients or other healthcare workers because of your ethnic background? Is that an issue that's you faced or have seen raised in our hospital?
Yeah, I'm not sure if that's what reverse discrimination is, but having said that, I will say this as a person of color, and I have been very fortunate. I have really not experienced a lot of overt racism as a practitioner. It's a little bit different, I think, in the community. I refer to a lot of the racism that it does exist here, or the ignorance as being benign. I think the minute I open my mouth and it kind of, I come out and it's not an accent, and they understand what I'm saying, and they understand that I'm making an effort, that I'm really just one of them. I think that breaks down a lot of barriers. Oftentimes I feel that that's very helpful. Having said that, I wonder often what happens to, like, you know, a lot of the family practitioners that come from away that practice in other parts of New Brunswick, where they're going into small parts of, you know, this province, and they're dealing with a lot of different people who have had zero exposure. I'm sure there has to be some element of that. We saw it a little bit with the physician in the northern part of the province who had all those issues around COVID. So I think it's there. I would be wrong in saying that it doesn't exist. But having said that, I do feel that there's an open-mindedness. It's just not always obvious. And I think, you know, I've had a lot of good discussions with our kids, with my kids, and with other people about this. And I think we have to be aware of this, and we have to be aware of the fact that discrimination likely exists, even if it's in a subversive form. Sharif, last comment.
My question was, well, it's more of a question than anything. How much do you think the disparity has to do with the fact that, you know, a lot of these people are younger that come and then leave, so we miss them, versus how much of it is due to access of care and maybe kind of getting dismissed a bit more, or, like, you know, what do you think is driving the lower numbers? Because I mean, like you said, you know, I see a lot more people around, but the number of people who I have in my practice who are ethnic descent is actually quite low.
Yeah, I think there's two factors. I think you identified one, which is, you know, a lot of the immigrants that are coming through now are young, and they're not of the age that we would expect to see them. Having said that, I think there is a barrier as it relates to language, a willingness to kind of get into the system. You know, especially the differential between men and women. I would speak for the Muslim community specifically. You know, there would be a discomfort amongst women seeking out physicians unless they were female themselves, for reasons that are obvious to me, but maybe not obvious to others. I think there's a lot of these sort of barriers that do exist. And I know the province makes a lot of efforts to try to accommodate people from, you know, in terms of like providing translation options to try to kind of pair them up with the right partnership as far as physicians are concerned. But I think inherently, you know, if you're going somewhere where you're not comfortable speaking the language, where you're not comfortable with the system, you're going to try to avoid engaging the system for as long as you possibly can until you absolutely have to. And these are all the problems that we've seen for years as it relates to just gender disparities in our society. Forget about Black versus white, ethnic versus non-ethnic. We're seeing that, you know, as far as gender is concerned. So I think, you know, I mean, unless we go out and with the Department of Immigration and the Department of Health kind of say, okay, look, this is something we want to tackle, and we want to really kind of educate these populations as to what it is that we can do for them and how it is that we can look after them. It's not likely that they're going to suddenly kind of flood your side on the other, from the other standpoint. So I think this has to go both ways, and we can't just sort of stick our head in the sand and assume that it doesn't exist. We need to kind of go look for it, because if we're already at 5% for just people of color or people of visible minority, and you add another 5 to 6% of people of Aboriginal descent, that's too many people that we're not seeing in some way, shape, or form, especially here at the Heart Center when we're supposed to be looking after everybody. All right. So with that, thank you so much, everyone. I appreciate your feedback and the comments, and I look forward to seeing everyone next week.